Hello, my name is Lauren. I'm from Nurse 2451, and I will be doing my Change Quality Management project, also known as our Plan, Do, Act, Study project on improving medication scanning rates to reduce medication errors. The issue I have identified is patient wristband and medications are not being scanned at the patient's bedside. At most hospitals, barcode medication administrative electric scanning system is implemented. It scans the patient's wristband and also scans the patient's medication. This is to verify the 5 rights of medication administration, such as the right patient, the right drug, the right dose, the right route, and the right time. In a study done in 2008, 1/3 of nurses reported they sometimes bypass the safety systems. Even though we have this system in place, nurses often find workarounds that compromise safety medication administration. Barcode medication administration is a great tool to reduce medication errors. However, integrating the BCMA within real-world clinical workflow requires critical attention to ensure technology safety features are used as intended, and that systems are designed to support this use. As with any technology in complex organizations, workarounds will occur. Both of these issues lead to increasing risk for medication errors. Of all medication errors, medication administration mistakes have ranked among the most common, harming at least 1.5 million people every year, according to a 2006 report from the IOM. As we look at quality variance, we look at evidence versus the expected standard performance. First, we'll look at standard outcomes from medication safety data by hospitals on a national standard metrics from the Leapfrog standards. Standards show implementing the BCMA systems linked to electronic medication administration records in 100% of hospitals and medical surgical units and intensive care units. They scan both patient and medication barcodes in 95% of bedside medication administration in the BCMA unit. Hospitals' BCMA system include all 7 decisions supporting elements such as the wrong patient, the wrong medication, the wrong dose, the wrong time, a vital signs check, and patient-specific allergy check, along with a second nurse checking as well. Hospitals have also implemented all 5 best practices, processes, and structures to prevent workarounds. Evidence has shown that the most common gap of 45%, not having the support elements such as vital signs and allergy checks. They also fell short on workarounds by 58% on establishing oversight committees and 57% observing efficiency of the process. Now we look at the root cause analysis. The main one is nurse workarounds. This includes omission of the process step, failing to scan the medication, and failing to scan the patient ID band. They also found that nurses have affixed copies of patient identification barcodes on the desk, such as having the patient's chart or having the patient's sticker and scanning that. They also have found that nurses are scanning one medication twice when administering 2 doses. So for example, 2 medications of the same, but scanning only the first medication. They also found steps out of sequence was a workaround problem. For example, documenting the medication before administering the medication or actually seeing the patient swallow the medication. Another problem was administering the medication and then documenting on it later. Another part of the workaround is unauthorized process steps. Workarounds that are disabling technology safety features or changing the process steps that are performed, which we'll go more into detail right now. The BCMA workarounds include technology, which is a really big problem at our hospital. A lot of the times the batteries don't hold a charge, or they need to be plugged in all the time, or sometimes they just die. The computers on wheels, they don't usually fit in the patient's room, or they need to be plugged into a hallway. Another part of technology is the BCMA system times out after a number of minutes. Let's say you're trying to give the medication to a patient and you leave the screen up and then it just times out. It also takes multiple scans to read the medication. So you're scanning the medication a few times and it's just not working for you. Some task-related issues are scan procedures that are slow or more difficult than other methods, or package is discarded without being scanned and medication is already administered. Some organizational workarounds include the medication order not in the system. Sometimes new orders come in and you go to give the medication, but it's not there yet. A lot of times, insufficient staffing is a big issue. As you're trying to give medications, you have other patients calling you that you need to attend to, or you have call lights going off. This leads to nurses always rushing to complete a task, and they believe it's justification to not have time to scan the medication. Partial or too long medication dose availability. So for example, 2 milligrams of morphine is ordered, however, you're getting a 10 milligram vial, having to waste that. Environmental issues, such as locations that don't allow appropriate use of BCMA system, such as wireless connections. Sometimes the scanners aren't working, sometimes the computers aren't working. So those are environmental issues that prevent nurses from scanning. A big part of the root cause analysis are barcode failures. A lot of the time, medications don't scan, or when you do scan the medication, the NDC number is not found. It's not in the system. A lot of the times, labels are missing, or barcodes are damaged or peeled off, or sometimes they're just unreadable. And then again, barcodes are hard to read the scanner. Sometimes it's a newer scanner and an old barcode, or vice versa. There seems to be an issue between scanning the medication and it actually coming up in the system. And I found this in a study. Because of complexities involving the use of BCMA, there are circumstances when nurses circumvent the scanning function of a BCMA to administer medications. Scanning circumventions, for example, typing the medication identification information by hand, manually entering the medication administration documentation into the record away from the point of care system, away from the patient, may be caused by a number of factors, including connectivity issues, computer issues, and a lack of machine-readable barcodes on the medications. So a lot of the workarounds prevent these issues, and then you just have nurses that go and manually enter the medication. And this could be also known as a medication error, because you don't know if it's the right medication. Now you don't know if it's what medication it is, what the dose is. There's a lot of issues that could arise from just scanning the identification number. So we'll define the scope of the problem, including the stakeholders. Pharmacy seems to be an issue because of the medications that aren't scanning into the system. A lot of the times, pharmacy print labels with barcodes for pharmacy prepared or patient-specific medications. So, for example, pharmacy mixing an antibiotic, or pharmacy putting patient label on a patient's home medication. That could be an issue for nurses. And then nurses have the responsibility to implement these 5 rights of medications at the patient's bedside. Visually seeing the medication, visually seeing the patient, also doing your 3 checks when you're grabbing the medication, your 5 checks when you're administering the medications. When they fail to scan the patient's barcode and medication, it could be a result of the wrong patient, the wrong medication. Could be a result of multiple things. And another stakeholder involved is, of course, the patient. They're the ones that are going to be affected by this problem. Approximately 44,098 to 98,000 people in the United States die annually as a result of medication errors, a substantial proportion of which attribute to medication errors. So we always hear about medication errors and patients being affected. Sometimes they have no effect on the patient, and then other times you're giving a patient blood pressure medication that you're not even aware of, and their blood pressure is already low. So that could be a major problem for the patient. Hospitals are also at risk or involved in the problem because of the medical costs to treat drug-related injuries occurring at the hospital. For example, this study accounted for $3.5 billion annually. So a few different stakeholders in the problem. And we'll go ahead and identify some solutions. So as far as the problem to bypassing the safety system, we want to set goals to follow the LEAPFROG standards, implement systems, and follow the policy and procedures. Do your five checks, your 5 rights during medication administration. Scan the patient and scan the medication at bedside, not outside of the room, not in the nursing station, at the patient's bedside. And then also implementing 5 practice processes and structures to prevent workarounds, such as formal committees, backing up the system, and including a help desk when there's an issue for scanning medications or computer errors. Also engage nurse leaders if there is a medication problem. As far as the problem to workarounds, our goal is to assess what the workaround is and address the problem. So for example, technology was one of the workarounds that nurses mentioned. So we want to get IT involved. We want to identify any computers or scanners that aren't working. We want to make sure that the software is up to date. I know at our hospital, sometimes we have downtime where they update the system, and now nurses have to document on paper. But this is a way to either clean out the system and to update the whole system, which is a good thing. We talked about some organizational issues, such as nurses feeling rushed or nurses not having enough time to scan medications. We want to be able to involve CNAs during medication administration, making sure they're answering call-outs, helping out, making sure that you have your vital signs in time. And environmental issues, such as location for computers, which, like I said, is a big problem in our hospital. You don't want the computers in the patient's room because now there's a lot of clutter, which increases the risk for falls. So you want to have some kind of set location for the computers on wheels. Another problem that we had identified is barcode fails. We want to identify why or which medications are not scanning, and we want to be able to fix the problem. So in one of the studies that I researched, the pharmacy follow up on the barcode problems, and they have containers that are placed in key locations, such as the medication room, which we have implemented. We have a bag that identifies medications that don't scan. So if they don't scan, you put them into that bag, and then pharmacy takes it. Another research involved pharmacy reviewing all electronic prescribed messages sent by nurses when a staff member identified a medication scanning issue. So identifying why their scanning issue popped up. And also, a lot of the times you come to an issue where you have to override a medication for whatever reason it is. One of the goals is to have a secondary nurse verify what the override is for. So now we want to be able to implement these solutions. One way is to perform monthly medication scanning rates for each unit as well as for each nurse. Also, attending monthly meetings to address what workaround problems are in the unit impacting safe care. We also want to involve pharmacy at these meetings to discuss maybe they know why these medications aren't scanning. They could help us out on what we do if they don't scan. And also include daily huddles is what we implement. Getting the team members aware of any issues, ongoing problems, and what we're doing to fix those problems on management side and also on clinical side. We also want to implement a nursing council practice to improve any kind of quality care, such as fixing the computers or getting some help. So once we implement these solutions, we want to analyze our data. So for example, at our hospital, we perform the monthly scanning rates per unit and also for each nurse. So for example, our medical surgical telemetry unit average scan rate is 87 to 89%. Each nurse percentage rate is based on a total number of medications that were administered for the whole month. So for example, medications that were scanned with a scanner was 12 out of 303 total medications for the month. And then medications manually scanned or manually entered in was 291 out of the monthly total of 303 medications that were given. I'm giving you a 100% scan rate and seeing that you didn't miss any medications, 0 out of 303. By performing measurable data collection, you'll be able to go to the nurse directly and find out what kind of workarounds they are having a problem with. So if they have below 87%, you want to know why they can't scan or why they're not scanning. What is it that's going on? If this is an ongoing issue, you want to identify these problems at monthly meetings, bring it up to your nurse leaders and bring it up to management. We have our CNO and also our CEO at these meetings, and they are more than welcome to hear what's going on the floor, hear what kind of problems we have for why we're not meeting the average scan rate. Also implementing a committee to specifically work on computer problems. Since this is an ongoing issue at our hospital, we have a committee to determine what the problem is with the computers. Some of them aren't holding a charge, so now we have to fix that problem. Some of the scanners are not long enough, or some of the scanners just don't work. So now you could implement wireless scanners or longer cords. Also, having computers in each room is ideal for our hospital. Some hospitals already have that, but our hospital seems to be a problem because now you have to find computers And also work with patient care and call the lights. You're already busy trying to pass out medications. Now you have to find a computer that's actually working, which seems to be a problem. We also do daily huddles and indicate the need for CNAs to assist during medication administration and shift change, during shift change report. So as nurses are passing medications and as nurses are giving shift change, we really need the help from the CNAs to address patient needs. A lot of the times nurses are busy passing out medications and then distractions come, and we all know that we don't want distractions while we're working on medications, because that distractions during medication could lead to medication errors. Some solutions that are effective are the monthly data scanning rates, which we have been doing for a while, and the nurse leaders tend to see a change once the nurse that has a low score is aware of the problem. Monthly staff meetings hold GAIN to identify issues and address them. Like I said, management really listens to what's going on. For example, the computers. So attending these monthly meetings, you get to address staff, nurses, CNAs all get to address what kind of problems are going on in the floor. Daily huddles help awareness on addressing patient care, and daily huddles are just what we go over in the monthly meetings, but within our nursing unit. We address all these issues so that way if there's different people coming in there, then they're aware and kept up to date of what's going on in the hospital. If solutions are not effective, then we want to make goals such as medication scanning rates of 87% at our hospital. If they're not met, then disciplinary action is taken in place. The main thing is improving our scanning rates and decreasing medication errors. So when those medication scanning rates are below 87, there's a problem. There's increased risk for patient safety and increased risk for medication errors. So we want to address that and address that issue. We want to always reanalyze the problem and regroup on changes that need to be made. If goals aren't met, regather on the problem, follow up, like I said, with pharmacy on the barcodes. A lot of the times they're still not scanning, so having pharmacy follow up in meetings and addressing what they're doing to fix the issue is a little bit of relief for the nurses to figure out what's going on. Also, getting the Nurse Practice Council and committee involved on research of what works at other hospitals is also a good way to implement a solution. So this was my project on improving medication scanning rates and reducing medication errors. Here are my references. Thank you.